Hello and welcome to another emergency Q&A for families in intensive care and intensive care at home. My name is Patrick Hutzel, founder and managing director of Intensive Care Hotline and Intensive Care at Home. You can find more information at intensivecareathome.com and at intensivecarehotline.com. So today we dive deep into questions from families in intensive care and intensive care at home once again. I do these live streams once a week so I can answer your questions live on a show here. And I also answer the emails that come in every week. There are numerous emails coming in every week, and it's been a very busy week actually. We've also had a networking event this week in Sydney for intensive care at home, and we put actually a live stream up there, so you can actually watch the live stream for our networking event in Sydney this week with some presentations from myself, from Kenise Hakim, our New South Wales nurse manager, as well as Amanda Riches, our NDIS support coordinator, and Trevor Forward from ResMed. So before we go into today's questions, if you like what I'm talking about here with my videos and on my channel, give it a like, give it a thumbs up, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Share this video with your friends and families, and also comment, what you want to see or what questions you have, so I can make the right videos and content for our audience. Now, before we go into today's questions, what makes me qualified to talk about and answer questions for families in intensive care? Once again, my name is Patrick Hutzel. I am a critical care nurse by background, having worked in critical care nursing for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I have been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives for our clients and members in intensive care. We've helped hundreds, if not thousands of members over the years and clients. And you can verify that we've saved lives on our testimonial section at intensivecarehotline.com. And you can also verify that on our intensivecarehotline.com podcast, where we've interviewed some of our clients to verify the work that we've done. With intensive care at home, we are currently operating all around Australia in all major capital cities. We are basically sending all major capital cities, as well as in regional and rural areas. We are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also for tracheostomy clients that are not ventilated, for BiPAP, CPAP without a tracheostomy, home TPN, home IV potassium, home IV magnesium infusions, port management, central line management, PICC line management, as well as Hickman's line management. We're also providing palliative care at home, ventilation weaning, and we're also sending our CCRNs into the home to avoid emergency department admissions. And we're basically providing an emergency department bypass service, which also takes the pressure off ambulance and paramedic services as well. So, and you can find more information at intensivecareathome.com and look up our case studies and testimonials there as well. So, without further ado, let's dive into today's question. The first question is from David, who says, Hi, Patrick. My mother is in ICU and starting to get stronger and more awake, but doctors use her sedation and said for her swelling to go down. But last CT scan was August the 8th, and it's been a week and 2 days, and she's breathing on her own, but she does have COPD. They're saying they don't want to take the tube out yet and want to do a tracheostomy, but not giving her a chance to see if she can breathe without a tracheostomy. What do I do to give her body time to heal without getting a tracheostomy? She does have high ammonium levels. She does have a UTI. She does have COPD. She does have liver cirrhosis. She's on lactulose. She's also still confused. She had a brain hemorrhage. And she's also still on fentanyl. How can we get the swelling down, and how can we avoid the tracheostomy? Well, and how can we get her to think more clearly? Well, David, thank you so much for your very detailed question here. So, number of things here. If she's confused and she's got cirrhosis of the liver, there's a very high chance she has high ammonium levels, right? High ammonium levels make the brain foggy and make patients delirious often, right? With a delirious brain, it is more difficult to wean someone off the ventilator because they often can't follow instructions and they can't follow, the breathing exercises, coughing exercises, and so forth. So the first thing that should be happening here is to get ammonium levels down, which often happens by giving regular lactulose so that bowel movement is happening more regularly. When bowel movement is happening more regularly, then generally speaking, ammonium levels go down. That's one thing. Definitely should be stopping sedation. She should not be on any sedation if her brain is foggy anyway and she's potentially confused because of the high ammonium levels, right? In terms of the swelling going down with liver cirrhosis, I would be very curious to find out what her albumin levels are. I would argue her albumin levels are probably low, which means with low albumin levels, she needs albumin replacement, and that might get the swelling down. Other ways to get swelling down might be to give her some sodium. She might have a low sodium level, and she might be fluid overloaded, right? And by giving some sodium, even 3% sodium, some of the swelling might come down as well. Furthermore, with the brain hemorrhage, it's been a bit vague on what you said in your email. I mean, is this a recent brain hemorrhage? Is it, is this an ongoing thing? Is it an acute thing? What's happening there, right? Is it recent or is this a long-standing? And how was it impacting before her ICU stay, right? Then COPD. How is the COPD impacting on her ventilator? One thing that is always good when you reach out to us is to give us ventilator settings. It's always good to let us know as much as possible about your case. Ventilator settings would have been incredibly important here, so I can actually, work out how far away is your mum from getting off that ventilator. Next, can they avoid a tracheostomy? Well, again, she's sort of at the 2-week mark now, close to anyway. So 10 to 14 days on a breathing tube with a ventilator is sort of the mark where someone needs to be considered for a tracheostomy, right? So with that said, what are the chances to get her off the ventilator? What ventilator settings is she on right now? Has she had some spontaneous breathing trials? Can she cough? Can she gag? How often do they suction her? What are her arterial blood gases like? Right? What are her arterial blood gases like? What are her chest x-rays like? Right? Also, to get some of the swelling down, she might also benefit, or she will benefit from some mobilization. Right? Can she be mobilized? Can she have physical therapy? Can she get out of bed? Right? But it's been a week and 2 days. And if she's breathing on her own, I presume she would be breathing in pressure support or CPAP. which makes it more likely for her to get off that ventilator, right? Also, what's the situation with her liver cirrhosis? Is she potentially on a liver transplant list? That's another question and consideration here to factor in, David. So I hope that answers your question. But when can she get off that ventilator? How quickly? How realistic is it? Once again, ventilator settings, arterial blood gases, chest X-ray results would be incredibly valuable to know. Okay, so let's get on to the next question from Russell. Russell says, "Hi, Patrick. The doctors want to have a meeting about my mother today at 12 p.m. about the oxygen tube being removed and the options since the tube has been in for 2 weeks now." I know that Russell is referring to the breathing tube. "I do want you to review the medical records, but it looks like I don't really have time on my hands for that, as the doctor is wanting to have a meeting today. So what do you think are my options to buy some time, to postpone the doctor meetings so you can review the file before needing to give consent to a tracheostomy if that is my only option?" Well, that is a great question, Russell, and thank you so much for asking. So this is about, again, a patient in ICU where ICU wants to push towards a tracheostomy and is asking for a meeting without much notice. And I know from the context from this email that, it's been around 12 days in ICU. And now all of a sudden the family is faced with this challenge that ICU wants to do a tracheostomy without giving them any warning, right? Without giving them any warning, without giving them any information. How can a tracheostomy be avoided? It's always interesting that it's often sort of bait and switch and there's not much warning. And then all of a sudden intensive care teams say, well, our only option forward here is a tracheostomy without actually educating families how a tracheostomy can be avoided and what the process needs to be to wean someone off the ventilator and the breathing tube, right? That should be the process here. So in terms of setting meetings, I've made countless videos over the years about family meetings with intensive care teams, and my approach is always only go into meetings if you have an agenda in writing, right? Only go into family meetings with intensive care teams if you have an agenda in writing, right? And then you decide whether you want to go or not. And maybe you want to add on your own agenda items, which I think is very important that you do that. But you can often only do that if you have at least a basic understanding about intensive care and about the treatment that's being offered or not offered in intensive care. That's really only when you can do that, which is, again, when we come in at intensivecarehotline.com, where we help with consulting, advocacy, insights, so that you make informed decisions, have peace of mind, control, power, and influence. So we also, part of what we do, just what Russell says here, is we do medical record reviews so that you can get a second opinion in real time. And we highly recommend that we do the medical record reviews before you give consent to a tracheostomy, before you go into family meetings with intensive care teams, right? How will you be prepared if you go into family meetings if you didn't have a second opinion from someone who understands intensive care inside out, right? So it's critically important that you get prepared, right? 99.9% of families in intensive care are completely unprepared. completely unprepared. They have no idea what's happening all around them. It is such a difficult territory. And it is, I mean, I've worked in critical care nursing for 25 years, and it's not until you've worked there for a few years until you can connect all the dots, right? You need to be able to connect all the dots, not just a few. That's the problem that I can see when I talk to families in intensive care and to our clients. They're connecting some of the dots, but not all of them. They're connecting not all dots, and that's just not good enough. You need to understand everything that's happening when you have a loved one in intensive care. So in a situation like that, should Russell's mom have a tracheostomy or not? I really don't know until I've seen the medical records, right? Very important in a situation like that I do see the medical records. So, and then I can advise you from there. It's such a major event, having a tracheostomy or not having a tracheostomy. You can't be flying blind, and you need to do your research from day one. This is the issue. People don't understand that. It's something you need to do your research from day one. You can't just leave it up to chance. You cannot leave things up to chance. If you're leaving things up to chance when you have a loved one in intensive care, it's the old sort of adage: if you're planning to fail, you're failing to plan. And it's very similar when you have a loved one in intensive care. And if you, like I said, if you're planning to fail, you're failing to plan. If you're failing to plan, you're planning to fail. My apologies. So, keep in mind when you have a loved one in intensive care, this is a once in a lifetime situation. It's a life or death. And too many families, well, 99.9% of families leave it up to chance. How can you leave it up to chance when you have a loved one critically ill in intensive care? It's not good enough. You can't leave things up to chance. And here's another thing. We have so many families in intensive care contact us 12 months later after they've lost a loved one in intensive care, after they have a loved one die in intensive care, where they say, oh, we have second thoughts now, right? And we think that maybe my mom, my dad, my brother, my sister, my spouse, whoever, maybe they would have had a chance if we hadn't given in, and if we had sought advice, and if we had sought a second opinion, right? Okay, let's move on to the next email from the next email is from Josh, who says, "Hi Patrick, my mother has a tracheostomy. She has been doing very well on her recovery, where she was on a T-piece for about a week. But the doctors keep pushing for a bag. Since we don't want the bag and my mother have varices in the stomach, they did a CT scan of her stomach, which I was aware of, but they didn't get my consent to stick a camera down her throat, which caused the bleeding in her tracheostomy and lungs, which caused her to get CPAP from the T-piece, and she has lost her progress. They did a CT scan of her stomach, which I was aware of, but they did not get my consent to stick a camera down her throat, which caused bleeding in her tracheostomy and lungs, which caused her to get CPAP from T-piece and have lost her progress." Yeah, that makes sense. So they would have done a bronchoscopy that would have caused some bleeding and set her back. That is terrible. "I've been hands-on with my mother's condition, and when I came in the next day, I knew something was wrong. Due to her being perfectly fine, handling the T-piece well, I found out someone in the hospital requested to do their own thing, and find out they were trying to find another way to send my mother to an LTAC by trying to do a peg feeding tube, which is not on file or requested from me, and they don't want to say who requested it. But staff have admitted to their plans. Reason they told me was to do the bleeding and her loss of progress overnight. I also noticed they were requesting swallow tests, but only when her ammonium levels of the liver are high, which gives a weaker swallowing due to her levels being so high and her being confused. And they cut her medication back on her lactulose. I see how they are playing with her levels and having their own agenda, which they are causing more harm than good when she had been making so much progress. I plan on taking it up with their safety team soon, because they are more worried about sending her to an LTAC than helping to give her a chance for recovery. No plan to action, and if they do, because I've been in closely looking at only the last couple of days and nothing. Also, her brain has been very good. She understands and is able to talk, is trying to get up, but she did get a rash that I had to get the head of the wound care team to get on it, because it's been some time and I haven't been seeing any improvement of the wound due to lack of care from the staff. I need her files reviewed, and I plan on having a sit-down meeting with them on the plan of care going forward. But I told them I need to see improvement on their behalf and their plan to action, because it's more about trying to find a way to put a feeding tube, i.e. peg tube, than focusing on her progress. I've been talking to a couple of directors to get her health on the right track, but we'll see. And some doctors are telling me, hang in there and keep fighting. And that management is pushing them. They're counting numbers. So if we can review to see where they might have messed up my mother's lungs or tracheostomy, to do them sticking a camera down, which is also known as a bronchoscopy, down her throat, to do their own agenda and for use, to see how we can move forward with getting her back on track, making sure she gets the help she needs. Thank you, from Josh. Well, thank you, Josh, for writing in and giving such a detailed explanation of your mum's situation. It looks today like we've got most sons inquiring about their mums. Anyway, look, obviously they've done a bronchoscopy, it sounds to me like without your consent, which is a concern. Unless it's an emergency, nothing should happen without your consent. The question is, why have they done a bronchoscopy? Is it because she needed one? She probably did need one. And you know, if she needed a bronchoscopy, question is why, and to what benefit was it? Because if she was starting to bleed, right, why did she bleed, right? I know from if your mom has varices, she's probably prone to bleed. So doing a bronchoscopy is potentially is a big risk, right? It's a big risk, you know, especially if she's already been on a T-piece for about a week. So just for anyone who doesn't know what a T-piece is like a trach collar or a trach hood. And it's basically the next step, trach collar, T-piece, trachea hood, when someone is being taken off the ventilator and can breathe spontaneously if they have a tracheostomy, right? So because she does have a tracheostomy, the T-piece is the right next step, right? There's no question about it. When is a tracheostomy being, when is a bronchoscopy needed? A bronchoscopy is needed when, you know, there's a lot of secretions on the chest that, you know, can't be eliminated and is causing more harm than good. Bronchoscopy is often needed if FiO2 requirements are high, if arterial blood gases are poor, if chest X-ray has shown there are heaps and plenty of secretions on the chest. That is when a bronchoscopy is needed. Now, and if the focus is on the peg tube, you know, that is also a concern. Again, I do know from your email, Josh, that you are in the US. So that is definitely a concern that, you know, if they do a peg tube, that they want to send her to LTAC as quickly as possible, right? So you have to question why. You know, I mean, you've heard me talk about LTACs for years here on my blog, that you shouldn't send your loved one to LTAC. You've heard me say on my blog, don't give consent to a PEG tube, which is what you're doing. You're not giving a consent to a PEG tube, right? And that will keep your mom in a safe place, which is ICU, right? So also, if she's got high ammonium levels, she absolutely should be getting those ammonium levels down so her brain fog can clear up. One way to achieve that is by giving her lactulose regularly. And with the lactulose regularly, that might get her ammonium levels down, right? So next, she's awake. She can obey commands by the sounds of things, even with a high ammonium levels. There is a rash, and you've got a wound care issue now. I hope they can take care of it. And you are acknowledging that you need your mom's file reviewed. And I couldn't agree more with you that, you need every family in intensive care needs the file reviewed by a professional, by getting a second opinion. Everything else is absolutely futile, right? So, Josh, I hope that helps you understand what you're doing now. Your next steps are keep avoiding the PEG tube. No need to give consent to that. A nasogastric tube is doing the job to keep your mom fed. And it's also doing the job to keeping your mom in ICU and not let her go to LTAC prematurely. It was just yesterday. I was talking to a client in the US, who has their fiance in LTAC, having gone from ICU to LTAC, not knowing what they signed up for, not really knowing what's about to come when they go to LTAC. And of course, lo and behold, she's not happy and she wants her fiance back in ICU because the care that he's getting is just so poor. No surprises there. Absolutely no surprises there. If anything, that's what we've been saying here for many, many years, that in the US, do not let your loved one go from ICU to LTAC under any circumstances. Never, ever. And I've done a video, a YouTube live a few weeks or months ago with the title 10 Reasons Why LTACs in the US Are a Scam. Right? And I stand by that. I'm not making any apologies for this title. Now, in the meantime, if you have any questions here, type them into the chat pad or join me live on the StreamYard. Keep it to relevant questions. Keep it to, ideally, if your loved one is in ICU right now, that would be good. If not, I have plenty of emails come in during the week that I will answer now. So, oh yeah, that's an email here from Deborah who says, "Hi Patrick, my brother is in a coma. His son and his mother are keeping my mom and my sister and brother from seeing him in ICU. What can I do?" Well, that's a good question, Deborah. It is kind of outside of my area of expertise because this often comes down to who has guardianship and who has power of attorney for patients and families. You will need to sort that out, with your family, potentially with a family lawyer if you wanted guardianship or a power of attorney. Something that you need to discuss with your family as well as potentially with a family lawyer. We get those questions a fair bit, and it is simply often a family law issue rather than, a clinical issue. I'm here to answer the clinical, not so much the legal stuff, because this is clearly legal stuff, I believe. Okay, let's move on to the next question. From Loretta. And Loretta says, oh, sorry. What is Loretta saying? Loretta says, "Hi, Patrick. My brother nodded yes when asked if he wanted some ice cream today. Again, he's in a medically induced coma for being septic, and they have been lowering the meds to try to bring him out of his coma slowly, and also are having a tracheostomy to be scheduled. Do you think that this is necessary to do a tracheostomy? Can you give me your personal opinion on what you think about the situation right now that I just told you about? Well, I can give you my professional opinion on it. I argue that if he's asked for ice cream today and he's in a medically induced coma, that, you know, he can't be in a medically induced coma and asking for ice cream, right? He must be awake. And one way, the only way really that patients are awake when they're on a ventilator in intensive care is that they're not in an induced coma, or they are just on mild and minimal sedation, right? So is it necessary to have a tracheostomy? Well, again, if he's asking for ice cream and he's still supposedly on medication, what happens if they wean off sedation? What happens if they wean off opiates? Will he be even more awake? Right? Will he be even more awake? That is the question. And if he's not awake, then a tracheostomy might be necessary. But if they can stop all sedation, and he's more awake and he's breathing up and he can breathe in CPAP pressure support with a PEEP of 5, with pressure support of 8, with good tidal volumes, with good minute volumes, with a normal breathing rate, he's awake, he's got a good cough, he's got a good gag, he can clear his own airway, he's obeying commands, then he should be ready to be extubated, and there should be no need for a tracheostomy. There should be no need for a tracheostomy, right? That is the bottom line. So that is my opinion on that. You asked me for my opinion. That is my opinion on that. But the question is, why is your brother in intensive care? You haven't shared that. Or septic, you know, he is septic. Have they got the sepsis under control? You know, is he on IV antibiotics? Is he on, you know, whatever medications he needs to be on to treat the sepsis? Most of the time it's IV antibiotics. You know, is he still on inotropes or vasopressor? Sepsis often goes hand in hand with needing other forms of life support, which means inotropes and vasopressors, right? Look, for anyone watching this or listening to this, most of the time a tracheostomy can be avoided in ICU. There are times when a tracheostomy can't be avoided, of course, but most of the time it can. But you have to start thinking about this from day one, right? And you have to ask the right questions from day one when your loved one is in intensive care, whether the tracheostomy can be avoided or not. You know, if you don't ask the right questions from day one, it is, as a matter of fact, very difficult for you to manage intensive care teams. But there are ways to manage intensive care teams. You just need to do it right from the start before they manage you. Right? Don't have intensive care teams manage you. You need to manage intensive care teams. That's one of the biggest mindset shifts that families in intensive care need to adopt, that you need to manage intensive care teams and not the other way around. Right? Yesterday, we signed up another client and their dad has just been in ICU for 1 day. And that's the time when you need to sign us up. That's the time when we can really handhold you best from day one, right? Get it all lined up into the right channel, right? Because when you come to us, when your loved one has gone to LTAC or is, you know, in an end of life situation that could have been avoided potentially with the right treatment, then it's often too late. So you have to do your research from day one. Now, if you have any questions, type them into the chat pad or join me live on the StreamYard link here and you can talk to me directly. If you have a loved one in intensive care, Next question is from hi Patrick, I just had a call from the doctor and he said my husband would benefit from a PEG tube and it doesn't have to be permanent. It can be removed and he can be fed by mouth as he can tolerate that. That would get the tube out of his nose, which probably is very uncomfortable for him. It's a way of feeding him. He also wants to do a tracheostomy, which would mean that he doesn't have to be on the ventilator anymore. And that doesn't have to be permanent either, as he can be helped to breathe through his mouth again. Can you let me know if they are good ideas, as I will need to sign for a tracheostomy and PEG at the hospital today or tomorrow? Well, and this is from Jennifer. Jennifer, thank you for your questions. Now, the first thing that I will say before I answer your question, you don't have to sign anything. You know, I can hardly believe, you know, when families come to us and say, oh, I have to go to a meeting tomorrow because they asked me for it. I have to sign consent for a tracheostomy because they've asked me for it. Well, why do you have to? Why do you have to? You have to do nothing. You can do it, and it's good to do it if it's in the best interest for your family member. But before you know whether it's in the best interest of your family member or before you know if it's in the best interest for the hospital, you shouldn't do anything. You should do nothing. Right? So let's break this down. He said, the doctor said Jim would benefit, or your husband would benefit from a PEG tube, and it doesn't have to be permanent. Okay. Well, here's the news. And again, this is an email from the United States, from a client from the United States. So, you know, we don't talk so much about PEG tubes in Australia or in the UK. This is in the US. It's just terrible that ICUs are pushing for PEG tubes prematurely and unnecessarily. So, doctor says her husband would benefit from a PEG tube. No, the only place that's benefiting from a PEG tube is the hospital. And here are the reasons why they benefit, right? The first benefit is it's surgery, it's money coming in, right? That's the first reason why they benefit. And I would call them out on that. And I've called out many hospitals when I'm talking to them on our client's behalf, right? So they're not benefiting from a nasogastric tube financially, but the client is, or the patient is benefiting from a nasogastric tube versus PEG tube. So here's the issue. When patients go from ICU to LTAC with a trach and with a PEG, especially the PEG tube, has the perception of a permanent tube, right? And if something has the perception of being permanent, nobody wants to change it. Yes, the doctor gives the sales pitch that it can be temporary, but the bottom line is most patients that get a PEG, it's actually permanent and not temporary. Because in the healthcare field, everyone who's dealing with a PEG thinks, oh, this is permanent. And everyone stops trying. Everyone stops trying, you know, starting to give feeds to a patient, right? Same with the tracheostomy, right? Is a tracheostomy permanent? No, and it shouldn't be permanent. Are there some cases where tracheostomy is permanent? Absolutely, there are. But they're mainly around when it comes to, you know, neurological conditions, when it comes to COPD, when it comes to cerebral palsy, motor neuron disease, and the list goes on, right? Again, before giving consent to a tracheostomy or to a PEG tube, the first question for you needs to be, what is ICU doing to wean your loved one off the ventilator? What is ICU doing to avoid a tracheostomy? That is the very first question, because then the question of the PEG doesn't even come up. You know, and like I've been saying in many of my videos, a nasogastric tube can stay in for up to 6 months, no issue whatsoever. And there's research out there that a nasogastric tube is actually causing less harm than a PEG tube. A tracheostomy and a PEG tube in the United States in ICU are conduits to send patients to LTAC. and do not let your loved one go to LTAC. I've made countless of videos about that, right? So there's absolutely no issue with keeping an nasogastric tube in. Now, there could be an issue with not doing a tracheostomy. There's no question about that. There could be, you don't want to have a breathing tube in for more than 2 weeks. And you then want to move on to a tracheostomy. But again, the first question is, what have they done everything beyond the shadow of a doubt to wean your loved one off the ventilator and the breathing tube? That is the first question, right? So, so I hope that helps you understand, what your next steps are. I would be really, really curious about ventilator settings once again. I would be really, really curious to find out what are arterial blood gases. I also would be very curious, what's your husband's mental state? Is he awake? Can he obey commands? And so forth, right? So I hope that helps. If you have any questions, please type them into the chat pad or join me live here if you have a loved one in intensive care right now, so that I can get to your questions. If not, I have the next question lined up. Just give me. Yeah, this week I made a video that I want to quickly talk about here. I made a quick tip video because I think this is something that keeps coming up over and over again. I made a video this week with the title, "Where's the urgency to end a critically ill patient's life in intensive care?" And I think that is a question that everyone who has a loved one in intensive care, who's in a real or perceived end of life situation, needs to ask. So this week we were working with a client as their 36-year-old brother in ICU. Paula has a question here. Paula says, "Hi, Patrick, my son is in ICU. He had a score of 4 and is still in a coma. The pressure is real." So when you are saying a score, you're probably referring to a Glasgow coma score of 4, and he's still in a coma. Pressure is real. So tell me why your son is in ICU. Can you tell me more? Do you want to join me here on the StreamYard link live, and you can talk to me directly? I think that way we can get your question answered very, very quickly. Just join me live on the link here. I've just placed it there, the StreamYard link. You don't need to go on camera by accident, okay? You don't need to go on camera, but we can get your question answered much quicker, Paula, if you are joining me here live on the show. So what pressure are you dealing with? What pressure are you dealing with? Does he have a head injury? What's going on? You're giving me probably 2% of the information that I need to know in order to help you. So you need to be sharing if you want help. Otherwise, I'll be carrying on and talk about, this week we were working with a client. There's Paula. Hang on. There we go. Paula, you are live on the show now. Can you hear me? It looks like you've got trouble connecting. Trying again.
Can you hear me?
Yeah. I can hear you, Paula.
Hi there. Well, it's rough. I am in ICU. My son suffered a traumatic brain injury after a bike accident, and he did have a helmet on. He is 32, and so we've been in ICU for 45 days. And right now his vitals are stable. His eyes are still dilated. He's only had trace trace movement in his eyes, but that's it.
Wow. Wow.
Yeah.
45 days. So what was the initial diagnosis? A traumatic brain injury?
Yes. Yes, anoxic traumatic brain injury.
What else?
And
Anything else?
well, he did have some internal injuries and a broken arm.
Right. But basically he's not coming out of the brain injury at the moment.
He's not coming out of the coma, but what they've relieved the intracranial pressure. That was a battle for about 2.5 weeks.
Yep.
And now they did a craniectomy, but he is his what's called a midline shift, paradoxal shift. And so they're going to go ahead and put the skull back in and put a shunt. They put one shunt in and it is not working. So they're going to have to test that shunt and possibly put another one on the other side. And it's a rough road. I've gotten a lot of conversations about, well, we don't know his quality of life. And, and I just thought, well, nobody knows that right now. It's unknown.
There's plenty of time, Paula, to talk about end of life in case things don't improve. I mean, at the moment, all efforts should be made to improve your son's situation.
Yeah.
And
that's how I feel.
Right. And is he still in an induced coma or is it a natural coma now?
Well, it's a natural coma. So he was induced for the first 3 weeks.
Yep.
And then they took him off of the paralytics, the phenobarbital and all of that. All of that got taken off. And his drug score went from a 35 finally down to a 10. And I'm assuming by now it's all out of his system.
Yep. And he's got a trach by now?
Yes, so he was vented, but he is breathing on his own. And
Okay.
our first MRI, the doctor said, well, it's not as bad as I thought. His spinal cord is intact. There is a lot of damage. However, I can see a lot of contrast.
What do you mean with contrast? They've done a contrast.
I don't know. In other words, he could see the contrast of the injury versus the good parts of the brain.
Oh, I see. Yeah. So
Yeah.
he had a CT or an MRI with contrast.
Yeah, he did have he had an MRI, and lots of CTs. He's had lots of CTs because he developed hydrocephalitis where he's just throwing off all kinds of fluid. And that's why they're going to go ahead and they've drained him. They've drained his skull. And now they're going to put a shunt in one. Hopefully that works. And then put his skull back in.
Yeah. Okay.
But there's something called a paradoxal midline shift.
Yeah. And are they still measuring his ICP, his brain pressures, or have they stopped measuring that?
No, they're continuing to do that. It's been between 2 and 5.
Okay. So okay, that's interesting. So they're still doing that, but it hasn't been high.
No. Only the first 2.5 weeks it was high, and it was a battle to keep it down. But now our battle is the fluid and overproducing fluid and ventricles that are dilated and throwing off more fluid and more fluid. So he's been draining now. Unfortunately, the interior shunt never worked, so they had to do an exterior drain.
Exterior drain. That's in his brain right now.
Yeah, draining.
Right.
Yeah.
And obviously his antidiuretic hormone is not working if he's producing too much urine. Is that what you're saying?
Wow, I don't know about that. Fluid? I was brain fluids, CSF.
Oh, brain fluids. Okay, I see. Yeah. Okay, you're not talking about the antidiuretic hormone. You're talking about
no.
CSF. Okay. Yeah. No.
Yeah.
That's okay. So where's the CSF coming out? From the drain?
From the EV, yeah, the external drain.
From the EVD.
Yes.
From the
The shunt that they installed never worked.
Right.
And
So
as soon as he's fit for surgery, they're going to take him in for surgery. They're going to replace the skull and put in another drain.
Wow.
A shunt.
Which, given that he's got an EVD now basically for 45 days, that's also a big infection risk.
Yes. Yeah.
But he hasn't thank God he hasn't had an infection.
Well, he has elevated his white count is up to 22.
Right.
And so they've got him on 3 different antibiotics. And the doctor will do the surgery as soon as his white blood cell count comes down. Then we can get the surgery taken care of and get his skull back on and get a shunt put in.
Right. And does he have any seizures?
No, not that I know of. EEG came back good.
And he's not on any anti-seizure medications?
I believe they have him on Keppra.
Okay, probably it would be on something. Most likely it would be on something.
Keppra, propranolol. There's quite a propranolol, Keppra. Yeah.
Okay. And once surgery is done with a VSD with the VSD shunt, what's next?
Well, if he wakes up, we can get into a really good rehab. If he wakes up, if he shows that a little bit of command, then we can get him right into rehab, physical therapy, and where they'll keep him stimulated and keep him awake. And yeah.
Okay.
So I know we have a rough road ahead, but we're willing to climb it.
Yeah, no, definitely. And he's completely off sedation now.
He is off sedation, yes.
Yeah, no, that's good. And no other, like you mentioned, no spinal injury, no other major injuries. It's really just a neurological issue now.
So he did have a C2 fracture. He has a Miami J collar on. So he's had that on since 45 days.
Day one. And he's nowhere near ready to have any rehabilitation stimulation. He's not getting any physical therapy yet.
No, we're just putting him in a seated position. This is our 3rd time where we're putting him in a seated position.
Right. Because one of the things that that is one of the risks here, if he's, and I understand with head and brain injuries, you can't start physical therapy and mobilization as quickly as with other patients, right?
Yeah.
One of the challenges that I can see is, if they're not starting to mobilize him, he might get contracted. His joints might get contracted.
Yeah.
Right. And I'm not sure whether, they are taking any measures there to even do light physiotherapy or physical therapy, because if he's waking up
I'm doing it. Yeah, I move his legs about 3 times a day. And I try to move his arms and shoulder, and I rub him down. I rub his muscles down and give him a massage. They do have leg cuffs on him to keep the calf muscles moving.
Yeah, good.
Yeah.
Good.
Yeah.
Because if he improves, hopefully, and you don't want him to not being able to rehabilitate because he's got contractions everywhere.
Yeah.
That would be good.
Yeah. Well, I'll just from you saying that, I'm going to up my schedule to 5 times a day, maybe more.
all the joints, knees, heels, elbows, arms, hands, all of it really.
Yeah. I'll do it. I'll keep in there. I'll
Yes,
up my schedule.
right, right. They should be doing it too. They should be
Yeah,
doing
so far,
it.
no.
Right,
No,
right,
because we're just in the ICU, and keeping them stable, but I'm the only one that does the physical therapy part of it.
right.
So
Okay. Look, it sounds to me like you are in good spirits, which is half of the battle.
yes, yes, it is. I cry a lot though. I do definitely have my moments.
Yeah, I can imagine. I can imagine. But
Yeah.
you shouldn't, don't give up. And if they're still going on after 45 days, I mean, they must see some hope as well, I would think.
Well, they do, but they're starting to give me that timeline and quality of life speech, and I'm just not wanting to hear that. I'm wanting to keep in the fight.
Yeah, yeah. And like I said, God forbid if things don't turn out, there's plenty of time to talk about end of life. But as long as he's making progress, even the smallest progress might get him to the goal eventually.
Yeah, yeah. And that's what we're working toward. We've got a little infection to conquer, um, and then try to keep pushing him forward the best we can. So I know they're doing, they've got him on like a ketogenic diet. They've got him on 2 or 3 different antibiotics right now, and then the anti-seizure Keppra medicine, and mantidine and propranolol
Right, right.
for
And,
neurostorming.
right. And is he having a peg tube already?
Yes. Yes.
Okay.
Yeah.
All
He's
right.
got a feeding tube. Yep.
Got a feeding tube in the stomach, not in the nose.
Correct.
Yeah.
In the
Okay.
stomach.
Yeah, yeah. Okay. Just be mindful that, if he does wake up, they might want to send him to an LTAC sooner than later. Just be mindful.
That has been the discussion. They've discussed doing an LTAC, and I thought we're trying to fight to stay here at the hospital.
Yeah.
Unless, do you recommend LTAC or
No, not at
stay
all.
at the
Not
hospital?
stay at the hospital.
Okay,
Stay at the hospital,
I think so.
or the only thing that I would recommend once he's more awake, to target neurology rehabilitation.
I've
Right.
reached out to a neuro rehab. Yeah.
That's what
Craig Rehab in Denver. Yeah.
Yeah, that's what I would be focusing on, Paula.
Yeah.
Definitely not LTAC. It needs to be very specific to what your son needs.
Okay. Well, thank you. That's exactly, we want to get out of here, get medically sound and stable, and then they'll downgrade us here, and then we want to go straight to the neuro rehab. No other rehab but neuro rehab. Yeah.
Yeah.
Yeah. So,
Okay.
but first surgery. But thank you so much for taking my my questions and concern. Your site has really helped me in this
Great.
this battle that I'm in currently.
Yeah, no, that's really good to know. That's wonderful to know.
Yeah. Thank you.
It's a pleasure. All the best, Paula, to you, your son, and your family.
Thank you so much. Take care.
And you. Thank you so much. Bye-bye.
Bye-bye.
All right. Thank you, Paula, for sharing. I do need to wrap this up here for today. I usually go for an hour. Thank you so much for joining us today. Thank you for watching it on replay. Thank you, Paula, for your questions, and thank you for sending your questions in during the week to anyone whose questions I answered today. Go and check out intensivecarehotline.com. Call us on one of the numbers on the top of our website. I do a weekly YouTube live. I do consulting and advocacy for families in intensive care. We also have a membership for families of critically ill patients in intensive care. We do medical record reviews in real time. We do medical record reviews after intensive care. We have helped hundreds, if not thousands, of clients over the years, and you can verify that we've saved lives on our testimonial and podcast section. Also, go and check out Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we're sending critical care nurses into the home for long-term ventilated adults and children with tracheostomy. We are currently operating all around Australia, in all major capital cities, as well as in regional and rural areas. We look after long-term ventilated adults and children with tracheostomies. We provide tracheostomy care at home BiPAP, CPAP ventilation without tracheostomy, home TPN, home IV potassium and home IV magnesium infusions. We are NDIS approved, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as DVA approved. We're also taking on private clients, and our clients also have received funding through public hospitals, departments of health, as well as private health funds. We're open for business there. Go and check out intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. And if you want intensive care hotline, go to intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. Like the video, subscribe to my YouTube channel, comment below, share the video with your friends and families. I'll see you again next week, and look out for my videos during the week. Have a wonderful weekend and take care for now. Bye-bye.